to another episode of our podcast from the Colombian Society of Cardiology. In line from the basis of the complex, we'll be talking about cardiac stress magnetic resonance, clinical utility for making practical decisions. For this, we will present in interview type format with a very special international guest, Dr. Amedeo Chiribiri, Cardiologist, St. Thomas Hospital, UK. And as the interview, we will have Dr. Carlos Guerrero from the La Cardio Fundación Cardioinfantil Bogotá, cardiologist specializing in adult congenital heart disease and cardiovascular imaging. Welcome, doctors.
Bienvenidos todos a nuestro podcast número 49, titulado Resonancia de estrés y su utilidad clínica en la práctica clínica diaria. Thank you, Dr. Chiribiri, for being here with us. So this is another podcast of the Colombian Society of Cardiology, and the idea is to share the basics of these new techniques with the rest of the audience. So audience, I want to introduce Dr. or Professor Chiribiri. He's the head of cardiovascular imaging at St. Thomas Hospital in the UK. Thank you for being here, Dr. Amedeo, and it's a pleasure.
It's a great pleasure for me to visit your center, visit Colombia. It's the first time for me. It's a fantastic country and you have a great team. Thank
you, Dr. Chiribiri. You're very kind. So let's start with the first question. What does stress CMR do? And how can we perform it? What we need to perform it?
Yes, so stress CMR is one of the methods for investigation of myocardial ischemia, which are recommended by the American, European and UK guidelines. Effectively, whenever you have a patient where you're interested in knowing whether myocardial blood flow is normal or reduced to the heart, then you have a choice between nuclear medicine, echocardiography with stress, and stress perfusion CMR. All these methods share the same high-level indication in the guidelines, and therefore, if the method is available in the local hospital, then it should be considered as one of the options. What makes easier the implementation of stress perfusion CMR is the fact that current CMR scanners are actually all capable of stress perfusion CMR, because one part of the scanner, particularly the gradients, are very fast, and every scanner, pretty much every scanner has fast gradients. So if you have a modern MRI scanner in the hospital with a cardiac package, it is likely that it will be capable to acquire these images. Now, the way the method works, it is a first-pass imaging technique. So the idea is that we stress the patient with a vasodilatory stimulation, either adenosine, regadenoson, dipyridamole, or ATP, depending on the market and local availability. We create a full vasodilatation in areas of myocardium which are supplied by coronary arteries, which have hemodynamically significant count, will likely have reduced the flow compared with fully hyperemic normal segments. We inject the contrast agent in a big vein, we track the first pass of the contrast agent across the heart, and that gives us the perfusion images. And then we can either analyze them by visual assessment, so a cardiologist or a radiologist all together, they sit in front of a screen and read the images, or alternatively we can use quantitative perfusion maps, where we get maps which are very similar to nuclear medicine at the SPECT or PET, with the additional advantage of the high resolution, which is typical of cardiac MRI.
Thank you for that thorough and very important aspect of stress CMR. So, going to the guidelines, what do you think is, what do the guidelines tell us about the use of stress CMR? Where does the stress CMR sits in the guidelines of chest pain evaluation?
Absolutely. So very recently the guidelines, both the UK guidelines and the American guidelines, have put more emphasis on the use of coronary CT in more patients. However, in a nutshell, I think where stress perfusion sits is whenever there is a need for the assessment of inducible ischemia, which, for instance, in a patient who already had a coronary CT, might be a patient with intermediate lesion, maybe multiple lesions or multiple vessels, or patients with calcified coronary arteries, where it becomes complex sometimes to judge the severity of the stenosis. And also patients with completely normal coronary arteries, provided that they have symptoms which are suggestive of angina, then with stress perfusion CMR, we can perform an evaluation whether they have or not microvascular disease. And that's an increasing indication for the scan.
Thank you, and that leads to the next question that was, what is the ideal scenario, but you already point that out. And then people want to know, I think, always specificity and sensitivity in this test. What can you tell us about specificity and sensitivity in stress CMR?
Absolutely. So the validation of stress perfusion CMR, it's something that took place in the earlier 2000s until 2010. And there are basically two groups of studies. Those studies which validated stress perfusion CMR against the coronary angiography, so visualization of the epicardial arteries for detection of epicardial scar, or on the other side, gold standard of fractional flow reserve. And then there are a few studies which use a PET. Usually ammonia PET, of course, that's not ideal. You would like to use water PET, but there are a few studies with water PET. And in terms of the sensitivity, that's extremely high. That's what all the studies are telling us. We are in the range of 90% for detection of hemodynamically significant CAD. And with respect to the specificity, we range from 80% to 90%, depending on which reference standard we are using. So 80% if you use an anatomical gold standard or reference standard like coronary angiography, and about 89-90% if you use a functional test.
That's incredible. Thank you for that very important clarification. And where do you think that stress CMR sits in MINOCA, in myocardial injury patients? Do you think that has an added benefit there?
Yes, absolutely. I think that's one of the main indications for MRI. We leverage on the capability of cardiac MRI to perform tissue characterization. So we do not just evaluate the presence or absence of ischemia. We can, of course, evaluate also late gadolinium enhancement for areas of fibrosis, but we can add T2-weighted sequences or T2 mapping, which give us an idea whether the patient is having, for instance, a myocarditis, or maybe a myocarditis with an associated pericarditis. And these are all differential diagnoses which should be considered together with microvascular disease in these patients. We can visualize areas of embolization, for instance. These are usually presenting as very small areas of ischemic scar. That's very relevant for MINOCA whenever the patient presents in atrial fibrillation or has a history of atrial fibrillation. So really we can open a window on the heart and in many cases really identify what's wrong.
That's quite amazing, the outreach of the stress CMR. And of course, you know, we have been driven by FFR for intervention in many studies. Do you think that there is a comparison between FFR and stress CMR? Is there any studies that tell us that a stress CMR can compare to FFR?
Yes, well, on top of the studies that we already mentioned for purely diagnostic validation, we also have in particular one study called MR-Inform, where CMR was tested against fractional flow reserve as the initial diagnostic method for the assessment of patients with suspected coronary artery disease. Patients are randomized in two groups, and then one group had a stress perfusion CMR, the other group was managed by fractional flow reserve. And what the study has shown us is that there is no excess of events if you use a non-invasive approach to the assessment of these patients. So it is very safe to use stress perfusion CMR, but CMR has the advantage of a catheterization and FFR of a much lower cost for the healthcare system, and therefore, if available, should probably be preferred.
So would you prefer the stress CMR?
Yes. Based on the MR-Inform data.
Yeah, thank you. That's very important for our healthcare system because we need to reduce the cost of the healthcare system in Colombia because our budget is quite restrained. And to that question, do you think stress CMR is the best gatekeeper of CAD? Basically, can we avoid the unnecessary CAD with stress CMR? And the other question would be, if it's a negative test, are we safe? Are we good to say, okay, you have enough good years without having an event?
Yes.
I think that would be an important question to answer, because that's what we think about SPECT at the end of the day. No?
Absolutely. So I think the warranty period which a normal stress MR gives to patients has been subject of many studies. I think the first study was a study from the group in Berlin from Cosima Janke, reporting the prognostic value of adenosine, and in the same study also the glutamine stress MR. What the data consistently show, there are of course many other studies published, is that a normal stress perfusion CMR effectively predicts a very low event rate, events in the follow-up. But what is really important is that CMR really has the capability to investigate multiple endpoints. So we can get perfusion, rate enhancement, function. And if you test all these different parameters in a multivariate model, then each one of these parameters, if abnormal, adds excess rate of events.
Of course.
And therefore you can really give a detailed stratification to patients. So again, CMR is a test which takes a bit longer than other tests. That's what we normally hear, but we acquire a lot of data, more than any other test. We acquire data which do not focus on a specific diagnosis, but can really give you a range. With respect to the use of CMR as a gatekeeper, I would not say that is the ideal gatekeeper or the only gatekeeper. It should be selected because it's still an expensive test for appropriate patients, but certainly it does have lots of appealing characteristics, and it has the same very strong indication in all the guidelines, US, European, UK, and therefore should really be considered if available. Availability is the problem. You should use the test that you have locally available.
And is the right test for the right patient at the end of the day.
Yeah.
Exactly. And of course, in your ground, of course, semi-quantitative or quantitative. So how can you help us approach this?
Yes. So semi-quantitative analysis is something that has been used in the early year 2000s for several research studies. Consists of methods which investigate the upslope of the signal intensity curves or the area under the curves. All these methods perform very well in small single center studies, but unfortunately these tests underperform in larger studies, and for this reason, even though the software is widely available, these methods are really not used. So the choice is really between visual assessment and for sites that have the software for the acquisition of the images, and for the analysis, of course, quantification, which is the next big advancement for cardiac MR in the next, I would say, 1 or 2 years. Really.
So I think we're going to move full-blown to quantitative, of course, in a few years.
I think visual assessment will still have a role, particularly for quality assessment. So if you find the map and you have the dynamic data and you can try to debug what went wrong with the acquisition, which is something which happens in the vast minority of patients, so it will be maybe less, around 1% or 2%. That will be the role for visual assessment. But quantification really makes the images very easy to interpret, whereas visual assessment is very complex. So we're really trying to make CMR as easy to use as, relatively speaking, of course, like it is to read a SPECT or a PET scan. You have a single colorful image, a still image, as opposed to many dynamic grayscale images.
Of course. I think that will help also the referral doctors to understand a little bit more, and not to think that this is like something obscure there that only few people can interpret it.
Okay.
So some final remarks. What are the key points that you want to teach our Colombian audience of cardiologists, interventionalists, electrophysiologists, and of course our fellows and general practitioners that might be hearing this podcast? Some key messages for them on the use and not abuse of stress EMR.
Yes, well, stress EMR is a highly accurate method. It allows you to assess patients in combination with viability testing with very high resolution. So it's a highly accurate method for both evaluations. And together with function, it provides all the prognostic factors which are relevant to the daily life of a cardiologist who is dealing with patients with ischemic heart disease. Ischemic heart disease is one of the big indications of cardiac MR, particularly for patients that have an intermediate to high risk of disease, and that's reflected by the fact that patients above the age of 60, they are mainly referred for CMR for a stress evaluation. And of course, for all the other patients, you can still assess presence of myocardial inflammation. If the query is myocarditis, you can use parametric mapping in the gain data enhancement and function to diagnose non-ischemic forms of disease. So effectively, consider using CMR for all your patients with heart failure. Heart failure is not a mystery. It used to be a relative mystery when I was in training many years ago. We had patients, and the first step was to perform a coronary angiography. In many cases it was normal, and that was our diagnostic pathway. Nowadays you can do the same with CMR, either stress or non-stress, depending on the symptoms of the patients, but you can really give a label to the disease in many cases, and that's the best application really.
Agree. And finally, for our radiologists and cardiologists that does imaging, what they should expect on the ramping up of numbers, because they might be feeling that they're gonna be swarmed with numbers. So do you think it's gonna be a steady coming up, or you're gonna think it's gonna ramp up until 50% of the practice? What do you think? What is your experience on that?
Well, of course, we hope that this method will be used more and more because we think it's useful for patients. I think it's very important to have a dialogue with your referrers inside the hospital, to have joint meetings where you discuss the cases, so that the doctor which refers the patient for the scan knows exactly what is the added value and doesn't send the patient to get a scan, which adds very little to the diagnosis. And this, of course, the additional value changes based on what you suspect as the main disease. However, we know from the literature that, and that's the Euro CMR registry, Oliver Bruder 2009, that up to 1 in 6 patients that have a cardiac MR, they leave the MRI unit with a new cardiovascular diagnosis, which was not even suspected before the scan. And that up to 60% of patients see the clinical management modified by the results of the MRI. So it's a very useful tool.
So thank you. So Professor Chiribiri, it has been wonderful spending time with you, and I think all the audience and the Colombian Society of Cardiology, thank you for your time. Thank you for enlightening us on stress CMR, and we're very happy to have you here. Yes. Thank you again.
Thank you very much.
We thank Dr. Amedeo Chiribiri for the key points discussing when addressing this topic of great relevance to our clinical, of the real importance in the diagnosis approach of the patient with chest pain, with and without no coronary artery disease, and new technology that's arriving in our country and that will allow us a more comprehensive evaluation of our patient, as well answer to determine the need for the myocardial revascularization. We invite you to continue listening to our podcast. For the next episode, we were talking about early use of statin and fibrates in prevention of cerebrovascular events. Not everything has been said. I am Alejandra Gallego Rivas, cardiologist at the Submarine Cardiovascular Center, Rio Negro, Antioquia, member of Society of Cardiology of Colombia, president of Chamber of Young Cardiologists, and it was an honor for me accompanying you in this episode.